These are some of my disclosures, and I need to indicate my gratitude to AstraZeneca for making it possible for me to be at this conference. Now, when we think about the GINA guidelines, we as physicians usually think about the treatment table. And this is the treatment table from the 2014 treatment. But this is a very medical view of what is contained in what I think attempts to be a patient-orientated practical guideline for clinicians. And so I need to point out the great impact that global guidelines like GINA have had upon asthma mortality. This is the the Global Asthma Network report for 2014, showing the mortality per million population from asthma. And although in countries like United Kingdom and USA, there is still a significant morbidity, and mortality rather, and especially in the developing countries, it's notable that more and more countries are having fewer than 1 death per million under the age of 45 years, 1 death per million, which is an outstanding success. I don't think there's any other disease that can claim to almost have eliminated deaths from that disease. Perhaps the exception may be infectious diseases like cholera. So we've made dramatic strides, and our treatment approach has been successful. But yet there remains a big unmet need. Now, the 2014 GINA guideline attempts to take a more patient-orientated approach. And the approach is really quite simple. Obviously, diagnosis, symptom control, assessing symptom control and risk factors. Very importantly, the patient-orientated points here of ensuring inhaler technique is correct, ensuring that patients are agreeing to take their treatment, and taking into account patient preference, because patient preference is a very strong determinant of adherence. So that is a key initial assessment that needs to be made. An agreement from the patient that they will not only take their medications, but they understand why they need to take it. And then, of course, we view the medications, we give medications, we treat modifiable risk factors, and then we review periodically. And that review involves symptoms, exacerbations, side effects, patient satisfaction, and from time to time, lung function. But I think the important part is at the bottom of this figure, where it says we need to have a patient partnership, setting goals with them, good communication skills, and listening to their medication, their cultural and their personal preferences, and health literacy. What do we mean by health literacy? Well, it's been shown that many people hear you, but they don't understand you, because what you say as a doctor does not fit into their concept of their body, or their concept of disease. So health literacy is becoming a very important part of the management of chronic diseases, not only asthma, but COPD, hypertension, diabetes. So these are fundamental starting points for the good management of asthma. How do we assess the components of asthma? Well, first of all, we look at daily symptom control, and our goal is to have completely or well-controlled asthma where we have none of these features of daytime, nighttime wakening, beta agonist use, and no limitation of activity. But another key aspect in the 2014 report is assessing for risk for poor asthma outcomes, and particularly the risk for exacerbations. Because we now recognize that exacerbations are not just a nuisance, an inconvenience in the life of an asthma patient, but indeed they are progression factors. They are involved in the progression of asthma to a worse level of asthma with progressive loss of lung function. And so our asthma strategy then is based around aiming for current control of asthma by the criteria I've mentioned, in order to reduce future risk of exacerbations, worsenings, lung function loss, and adverse sides of effects of treatment. But I need to emphasize that this is the doctor's agenda. That's a very medical view of what the patient wants. What the patient wants is a normal life, free of the hassle, free of the inconvenience of asthma. So part of that assessment of risk for poor asthma outcomes is risk factors for exacerbations. And here we have from the GINA tables, we have the risk factors. So a previous ever been intubated for asthma, uncontrolled asthma symptoms, even one exacerbation in the last 12 months, low FEV1, continued smoker, and incorrect inhaler technique and poor adherence are key. And then there are other risk factors that you can read here for yourself, but these should be part of every asthma assessment. Now I want to go on to looking at some of the treatment strategies and what is new within the guideline. So the traditional approach, the preferred treatments, is low-dose inhaled steroids at step 2, moderate or low-dose with ICS-LABA at step 3, high-dose ICS-LABA at step 4. And then the new addition here is that instead of as-needed SABA here, we can give a low-dose inhaled corticosteroid with formoterol, because formoterol has a rapid onset of action and is as good as salbutamol or any other short-acting beta-2 agonist. So as we explore that, I like to make some points about therapy. So we're talking about steps, and here are some points that doctors often forget. That the steps are not equal. You'll see that in the new guideline, what we describe, we show step 2 as being a very big step, because most patients can be successfully managed at that step. And the steps get smaller as you go further. Secondly, most patients will benefit from the early treatment, and each treatment has a ceiling effect, meaning it can achieve so much but no more. And so it doesn't always help to go on increasing the dose of inhaled steroids if they don't respond. Sometimes we need to change the strategy or introduce a second treatment. Next, steps are not of equal height, meaning medications on the same step are not equally effective, and I'll show you some comparisons. And efficacy may differ for different endpoints. So some treatments, as I will show you, are better at achieving symptom control, and other treatments are better at preventing exacerbations. And then each treatment has different efficacy and effectiveness differences. That is to say, some only work on specific phenotypes of disease. They vary with regard to safety, which becomes a barrier to their use. For instance, oral corticosteroids have a very bad safety record, although they may be moderately effective. Cost and patient preference are also barriers to increasing treatment. So I want to make a few of these points as we go along. So this slide shows the differential effects of a LABA and an ICS on asthma control and exacerbations. And this is the famous FACET study done many years ago, 1997. And on the left-hand side, we have the prevention of exacerbation, or the exacerbation rates. And you can see that budesonide 800 plus formoterol achieved the lowest exacerbation rates. This is the benefit of adding a formoterol to budesonide. But the biggest difference was in the dose of budesonide. 200 micrograms was not as effective as 400 micrograms, and 800 micrograms a day. And 800 micrograms was better than low-dose ICS plus formoterol. But if we look at clinical symptom control, that is episode-free days, we can see that, although budesonide did very well in terms of symptom-free days, actually the higher dose was only slightly better. So increasing the dose made very little difference here, not the same difference as we saw there. But the addition of the LABA made a big difference to the number of episode-free days. So that is to say, LABAs are more effective in symptom control, but not as effective in preventing exacerbations. Now, the GOAL study, which is also a fairly old study, but an important one, showed that as we increase the dose, the benefit from the higher doses gets smaller and smaller, whether it's inhaled corticosteroid, fluticasone here, or the combination. The lowest dose achieves most, regardless of which severity of asthma, but adding a second dose does achieve more asthma control. So this supports the step-up approach that is proposed. So if we look at a schema like this, as we pass from uncontrolled asthma with severe exacerbations, the main and very important treatment is to increase the dose of inhaled corticosteroids. The LABA helps a little bit. We saw that in the GOAL study, because what we saw here was that more patients achieved control when a LABA was added. So we get benefit in terms of symptom control, but it's only but as we get towards well-controlled asthma, the LABA becomes more important. So bear that in mind. If you have a patient who's an exacerbator, concentrate on the steroids. If your patient is very symptomatic, concentrate on the bronchodilator component of your asthma management. Now, another point to be made from the GOAL study is that all patients are at risk of exacerbations. Some are more at risk, and that's why we assess for exacerbation risk. But the biggest risk of exacerbations is uncontrolled asthma. If you do not achieve well-controlled or total controlled asthma by guideline amount, you can see the exacerbation risk is increased greatly in those patients, even if they have some symptom control. So these are the patients who we should target for prevention of exacerbations, and we should use medications that are effective for that endpoint. And I'll show you immediately from this slide, from GOAL study, you can see that patients who are on a LABA ICS, even though they weren't controlled, still had fewer exacerbations than those who simply remained on high dose of an inhaled corticosteroid. Now, we did an analysis of studies using, I beg your pardon, I'm going backwards now. We did an analysis of patients who had been treated with the SMART approach. And I'll remind you that the point about the SMART approach is that it's a single inhaler. So the patient uses the same inhaler for relief of symptoms as they do for maintenance. And the rationale behind that is that for several days before patients have a full exacerbations, they begin to be bothered by their symptoms. If we wait till they come to the doctor for oral steroids, we've waited too long. But if, when they first become bothered by their symptoms, they use their combination inhaler, and so in reaching for their rapid-acting bronchodilator, they also get a dose of inhaled steroids. And by doing so, one's able to prevent exacerbations. Now, that's very nice in theory. We now have independent trials done not by the companies, but by independent researchers that prove that this hypothesis is correct. We did an analysis of about 14,000 patients in 6 major trials using this SMART approach to try and understand the difference between symptom control and exacerbation risk. And this charts I will show you compare asthma symptom control here and exacerbation prevention. So let me take you through that. In this comparison, we compared high-dose inhaled steroids with budesonide formoterol as maintenance reliever. Let's just call it SMART. And you can see that asthma control was better with the LABA ICS than with high-dose ICS, but that's no different to what we saw in the GOAL study. The combination treatment is better, and the exacerbation rates were lower. So undoubtedly, LABA ICS is more effective, so that is not novel. And that was a statistically significant difference. But the real interest is in this analysis, where we compared a low-dose combination, regular dosing, with a high-dose combination, and LABA ICS. And you can see that increasing the dose of an ICS in the combination did not achieve any more. Here is the ceiling effect that I talked about. About 55% of patients over the course of 6 months or 12 months achieved a level of GINA control or partly controlled asthma. But if we look at the, and when it's compared with SMART, you can see that SMART does not do better. So SMART is not for achieving better control. It is actually for preventing exacerbations. Now, I need to point out here that we did a comparison of patients from the GOAL study, and the value in the GOAL study was 62 for patients in this category, so very similar. Because LABA-ICS, regardless of the dose, has a ceiling effect. So what does that mean? If you need better symptom control, you need to add a third controller. Don't keep on trying with LABA-ICS as though somehow, magically, by increasing the dose, you're going to have further benefit. All you achieve is exacerbation reduction and side effects. So let's look at exacerbation reduction. So here was the lower dose of budesonide formoterol week by week during the 52-week studies. If we doubled the dose, higher dose, we got an exacerbation reduction, just as we would anticipate because the steroid dose had been increased. But SMART was better than that. Even we got a further increase by using the SMART approach. So this is an important there's a series of points to remember. Now, in the COMPASS study, which was also involved the SMART approach using either salbutamol fluticasone, budesonide formoterol in fixed dosing, or the SMART approach, you can see that SMART approach was better than these higher doses. You can see the doses here. 500 micrograms of fluticasone or 320 micrograms twice a day of budesonide. Well, the SMART approach at just 160 micrograms of inhaled steroid achieved a greater exacerbation reduction. And very importantly, as far as ACQ is concerned, which is asthma control, there was an improvement in asthma control with all three treatments. So the only difference was exacerbation reduction achieved with the SMART. So this is a separate study showing exactly the same thing. We also published a paper looking at the different GINA steps, looking at patients failing GINA step 2, step 3, step 4, and you can see that patients on each of these steps, if we added in the SMART approach, there was a further reduction in exacerbations. And that is why in the treatment scheme you saw the recommendation is at step 3, 4, and 5, one can add the SMART approach as an additional strategy. Now here is an independent study performed in New Zealand, and this study is very important because it was done by investigators who believed that the SMART approach was dangerous. They were concerned that patients would take too much as needed salbutamol, at least formoterol budesonide, and therefore they would be at risk and maybe even death. And they were surprised because they got exactly the same reduction in exacerbations with budesonide formoterol as in the previous trials. In fact, there was a 46% lower exacerbation rate in only 6 months. So it was shown to be just as effective in these patients who were categorized as at risk of severe exacerbations. So a highly effective treatment. And in a separate independent study authored by Professor Papi, who I gather is also at this conference, last year they showed using a different combination, beclomethasone with formoterol, that they were able to reduce exacerbation rates by means of using the SMART approach. And here, again, about a 40% reduction in exacerbations. So there seems little doubt that that is an effective strategy. We performed this analysis because we were interested to know whether the SMART approach only benefits people from, say, allergen-induced exacerbations. So we did an analysis of patients reporting of symptoms of a cold, an upper respiratory tract infection. And we did an analysis of the frequency of these episodes of upper respiratory tract infection. And you can see that across the world, there were 3 times more cold symptoms in winter than there was in the summer. And the frequency of cold symptoms was the same in the group that had LABA-ICS with fixed dose versus those that were using the SMART. But the interesting point was that that in spite of that, patients who took the SMART approach had a reduction through summer and winter in exacerbation rates. So what is that to say? Well, it means that we don't prevent colds by using the SMART approach, nor with any of our asthma treatments. What we prevent is them turning into an exacerbation. And of course, as you know, in pediatric practice, about 80% of exacerbations are precipitated by the rhinovirus or one of the upper respiratory tract viruses, and the figure in adults is about 60%. So this is about 60% of the patients we see will benefit using this approach. Now, I will just briefly talk about the point that not all controllers on the same step are as effective. So here we have the alternative controllers, low-dose theophylline or a leukotriene receptor antagonists, and these could be added at the next steps as well. Now, one of our problems in GINA committee is that there are so few good trials of add-on therapy at these steps. There are more for step 2 than step 3. So let me show you one of those analyses. So this is 2 systematic reviews of exacerbation prevention. So we're talking about preventing exacerbations using either montelukast or zafirlukast. Now for montelukast there are 20 trials. And here you can see from the odds ratio that montelukast as a first controller is more effective than placebo, and that's why it appears there as an effective first-line therapy at step 2. It is less effective than inhaled corticosteroids and much less effective than a LABA ICS in controlling exacerbations in adults. We're not talking about children, but adults. As a second controller, it's not as effective as a long-acting beta agonist, but it is an option as an add-on treatment at step 3. For zafirlukast, the story is there are fewer trials. There were just 12 trials. And as first controller, it was better than placebo, but much less effective than inhaled corticosteroids, about the same as with montelukast. But it was not effective as a second-line controller. So that it does not seem to be a good strategy if you're wanting to reduce exacerbations. Now, one of the interesting facts that you'll be spoken about often is the importance of real-life studies, what are called real-life studies. Because we know that randomized controlled trials tell us that a treatment can work. A real-life study tells us whether it does work when you use it in the community. And recently we published a paper, last year we published a paper with what we called the ecology of care and population, the framework for defining studies. When we perform a randomized controlled study, our population is very, very clean. We ensure they don't smoke, we ensure that they have got asthma, we select the patients carefully, and then we treat them with a highly controlled protocol. What we're really interested in is what happens in reality when anything can happen and the population may be very broad. And so there is a gradation of different types of research we can do. The one that I have been doing a lot in my unit are pragmatic randomized trials where you control for certain features but not for others, and these often have a cluster design. Now, the reason I'm sharing that is that you're going to see a lot about that in the asthma literature in the coming years. So here is one real-life study. This is a study done by David Price in the United Kingdom, comparing montelukast with low-dose ICS at step 2 as first-line therapy. And you can see that the primary endpoint was roughly the same for AQLQ, that's quality of life, ACQ, that's asthma control, and peak flow. Technically, however, the endpoint was not met, meaning that there was not equivalence between these two treatments as first-line controllers. But what I want to show is one of the dangers of a real-life study. Because what can happen in real life is crossover. Because doctors are allowed to treat patients, they randomize them to the one treatment versus the other. But if the patient needs a change in treatment, the doctor is allowed to change the treatment. So it's very important to study the crossover effect. And here we have the crossover in this trial. So the patients on leukotriene receptor antagonists, about 30% of them had to increase their doses. They crossed over to inhaled corticosteroids, whereas none of the patients, or only a few patients, 4 patients crossed over to leukotriene receptor antagonists, and those that needed an improvement had LABA added, which is really a real-life way of saying that if a patient fails a weak treatment, doctors move on to the stronger treatments in order to achieve control. So I think this is a very interesting observation. Now, what about theophylline? Well, there's very little evidence for theophylline use in the chronic management of asthma, and yet in many parts of the world, and it may be like that in Mexico, it's still used very widely because of the convenience of an oral medication. But I've summarized here the only 8 trials that we could find which speaks to the efficacy of theophylline. And they're very poor trials. They're not of the same quality as the other trials that I've shown you. But they do suggest that there is some reduction in exacerbations, that patients lose control if you take away their treatment, and that it will improve control if added to ICS. And that's why they appear in the guideline. But you need to understand that the evidence base is not very good. Now, what about new potential treatments for steps 3, 4, and 5? And I don't have time to deal with that comprehensively, but I would just make 1 or 2 points. The striking addition in the 2015 GINA guideline is the addition of the antimuscarinics or anticholinergics, realizing that muscarinic receptors are more effective in the proximal airways and beta-2 receptors much more in the distal airways. So there's potential for using them together, either together or as alternatives. And the TELC study performed in the USA some years ago made a direct comparison between either adding tiotropium, LAMA, or salmeterol, or doubling the dose of beclomethasone. And you can see that for several of the endpoints, adding a LABA or a LAMA was more effective than doubling the dose of steroids for morning peak flow, trough FEV1, and asthma control days. So there already we can see that the effects of an anticholinergic and a LABA are very similar on asthma control days and on morning peak expiratory flow rate. An analysis was done on that as to how many people benefited from tiotropium more or salmeterol more, or both of them the same. And you can see that many patients got the same response to both of them. But there were similar proportions of patients who got benefit from salmeterol and tiotropium. So this gives us another option. If a patient doesn't have a good response to the one, we have the option of trying the other. So this was the lung function endpoint. What about asthma control days? You can see the pattern is exactly the same. So we have another drug here that we can add at step 3, and it's been approved in certain countries already. This is a very recent study published this year that looked at moderate asthma, adding it as monotherapy to an ICS alone, and compared it with salmeterol. And you can see that the effect on peak FEV1 was identical over 6 months with either treatment. So it was an either-or situation in terms of benefit. And if you look at ACQ responders, that is asthma control, you can see that the odds ratio of improvement with tiotropium at 2 doses or with salmeterol were just the same. The responder analysis was about 66% of patients. And of course, there are good reasons why we could use a beta-2 agonist with an anticholinergic. So beta agonists work directly on smooth muscle, but they also work on the afferent nerve endings, and they can have an action on inhibiting acetylcholine release and so preventing bronchoconstriction. At the same time, giving an antimuscarinic has a direct effect on the M3 receptors on smooth muscle and will cause bronchodilation. So we now have studies where these are combined with good effect. Now, my last point is just to mention mild asthma, and you're going to see a lot about different approaches to treating mild asthma. Are there better ways of treating it? Well, there are currently 4 different treatments listed in the 2014 GINA guideline for that severity. The favored one is low-dose ICS plus as-needed SABA. But we can use a leukotriene receptor antagonist. We could use a low-dose combination, but this, of course, is more expensive and does not improve on inhaled corticosteroids alone. But there will be a lot of interest in using intermittent treatment, and there are currently trials underway using intermittent inhaled corticosteroids and also intermittent LABA ICS. Now, the attraction of using, for instance, a LABA ICS only as needed for step 2 and maybe step 1 asthma is that we will then not change our approach when we move from step 1 to step 2, step 3. It will just be using it as needed and as maintenance as often as needed. Better adherence is likely. It's a much simpler regimen. It adapts to patient behavior, and it's likely to be preferred by patients. So that's something to look for the future. So I end by saying our current treatments are highly effective. There's an art in managing the drugs that we have. It's not simply looking at the chart, but to understand the differential effects of different treatments. I've talked about the value of changing our methods of treatment towards an as-needed use of a LABA ICS, talked about anticholinergics and potential new approaches in mild asthma. Thank you very much.